and that is to develop, evaluate, and implement health information leaflets on tobacco use for the support staff at Rhodes University in a way that is culturally sensitive and contextually appropriate, using a community-based participatory research approach. So what I'll be covering in this presentation will be the rationale for the research, the broader study, the aims and objectives, the method, the results, and the conclusion. So as everyone knows, tobacco has been around for many years, and literature states that it used to be an issue for higher income countries, higher socioeconomic groups, and it is now shifting towards lower and middle income countries and lower socioeconomic groups. And that is a huge concern for developing countries such as South Africa with a fragile economic development state. And a major catalyst to this whole thing is tobacco companies targeting developing countries and youth and women in particular. And proof of that is that 80% of the 1 billion global tobacco users reside in low and middle income countries. It has devastating effects on our health, affects each and every organ in the body, especially non-communicable diseases, which contribute to 63% of global deaths. It also impacts the economy, the healthcare budgets of the government, as well as household budgets for the use of these tobacco-containing products. There are 44,000 deaths per year from South Africa, and what is most shocking is that more than 600,000 of these, the 6 million deaths globally, as a result of passive smoking, and this figure includes children, which shouldn't be the case. So just to put it into context, there are other factors contributing, such as lack of physical activity, harmful use of alcohol, unhealthy diets, and as with the alcohol use, tobacco is centered right in the middle. It contributes to injuries, fires, road accidents. It also contributes to communicable diseases, to increasing the susceptibility and aggravating tuberculosis, communicable diseases. And it contributes to each of the non-communicable diseases, resulting in 43% of South African deaths and increasing as we speak. And coronary heart disease, other cardiovascular diseases have contributed to a $1.8 billion budget between 2006 and 2015, which already affects the dwindling development of South Africa. So why should this be? Why should we continue in this trend when all of it can be prevented? So first of all, South Africa is positioned in a nice space. What I mean by that is that we have a huge advantage, and that is the rich human resource that we find between the age group of 15 and 69 years, which if used properly could contribute immensely to sustainable development in South Africa. The bad point of this is that there's only 35% of this population is economically active, and a major contributor to this is because of poor health and non-communicable diseases in that way. And then, or we can go further to speak about the fragile state South Africa is in, and the major impact that tobacco use has on that. And that has been published at the beginning of the year based on my first objective in my study, if you want more information on that, as well as the global, what has been done globally, sustainable development goals, the global action plan, and strategies put in place by South Africa. I identified the different gaps and things that happen in the countries and policies, what has been done, what worked and what did not work, and that we published at the beginning of the year. So now what am I going to do? What can I do about the situation? Is to work in a collaborative partnership with the Rhodes University peer educators to develop a culturally sensitive and contextually appropriate workplace health promotion intervention on tobacco use with support staff at Rhodes University. You can see that I highlighted the word with, because it's not for the support staff, but with the support staff in a community-based participatory research approach. So how do we achieve this aim? The 4 main phases. The first phase would be the exploratory phase, and in this phase you start off with the global picture, where you first assess the gaps in policies and practices, what has been done, what has been successful, what did not work, and how can you act on that as well as globally in South Africa, Rhodes University as well. What are facilitating factors and what are the constraining factors to initiate such a project? Secondly, now to develop the implementation phase, and this is then the health promotion educational intervention to address the tobacco-related issues. And one of the methods would be to design and test a culturally sensitive and contextually appropriate health information leaflet to be used by the peer educators This leaflet will then go to act towards sustainability. It will go into a health promotion manual. This health promotion manual will then go on to the healthcare center at Rhodes University. It will be used by the community engagement office at Rhodes University. It will be used by the institutional wellness specialists at Rhodes University, and also by the peer educators when they go forth in implementing such strategies. I will explain on that later. Then the implementation phase and evaluation phase, that this is still in progress. So how did the method, the project participants consist of 1,500 support staff at Rhodes University. And of this 1,500 support staff, 40 of them are peer educators. And they are already part of an existing group. They consist of tobacco users, non-tobacco users, and from all different backgrounds, meaning culturally and educational backgrounds. And therefore it provides a nice perspective on this issue when you work with them. And the nice, interesting fact about this is that 60% of the Grahamstown community is employed at Rhodes University. So this gives you access to that rich human resource that we have at our fingertips. So this is just a background of them. These are a few of them. You can see they work in all different departments, some in central cleaning, housekeeping, all these different areas, so all scattered around the Rhodes University campus. So they used to work for the HIV and AIDS program at Rhodes University. They called themselves stigma breakers. They provided information. They referred people for help. They raise awareness. They distribute leaflets. They work together with other divisions at Rhodes University to then work towards HIV and AIDS, the program that they used to run. And so most of them were female. They're 41 to 50 years age, like Xhosa speaking women. And the majority of them completed grade 11 and grade 12. And this provides the perfect foundation for us to now start off with the health promotion education project. Using their formal education, they are guided by the principles of Ubuntu, their social responsibilities at home and at work, and with the experience of the HIV and AIDS program, to now converge that towards a health promotion project, where we then grow them as leaders in health education, health promotion at Rhodes University and in the community, with skills such as community empowerment and everything that goes along with that, and the importance of teamwork and what we can bring to the table, and how to conduct a project that is sustainable. So we started off first, we got ethical approval by the Rhodes University Faculty of Pharmacy Ethics Committee. We then had a workplace health assessment, so we then had to see what worked, what didn't work. We had semi-structured interviews with managers from Rhodes University, support staff, all the way from ground and gardens up into the human resources department, to hear the perspective of management on these issues. Is it a concern? Is it working? Is it not working? What do you suggest we do? Because this is a collaborative initiative. And then question guide was used for the structured interviews. The question guide was used for focus group discussions, which was now held with the support staff at Rhodes University to hear their perspective. And then we identified the group volunteers that we were going to be working with. Phase 2 is still underway with the developing and testing of the health information leaflets that I will cover now. So what were the results from the semi-structured interviews with the managers at Rhodes University? They said there were policies that were put in place, there were some interventions that were put in place, but the issue with these were that they were inadequate, and there was no one to take ownership of them, and no people were not working together in all of this, and therefore they were really happy that I stepped forward with this project. And about a month ago, the university came to me and they said, Theo, we want to implement smoke-free places all over campus, and we would love for you to be a part of this. So it really shows that they really want this done, and it showed that it is a concern. Also, they said the initiatives were unsustainable, and generally support staff were just unaware of policies and initiatives that were conducted at Rhodes University. And they suggested we go forth to work on health empowerment in a way that is culturally sensitive and that is sustainable in the end, to do all of this in a collaborative partnership. Focus group discussions with the support staff, then after the arithmetic analysis of the data corpus, revealed that the support staff they said tobacco use is an issue. They related it to health, and they said they felt this great need to grow their knowledge. Once they grow their knowledge, they felt the responsibility to now go out and help others and prevent all of this from happening. So it was suggested that a health promotion initiative would be fit to address all these different issues. So now for the first health information leaflet, the first draft was created and it was peer reviewed by the health promotion team in pharmacy practice, as well as an external reviewer from Norway University. We then used those inputs to put together draft 2, which then went out to the pilot study. The pilot study was not just conducted with the core peer educator group, but also with the end users, the Norwich University support, the 1,500 support staff at that moment. It then went back to the peer educators to now say, okay, what we have done, is it still okay? Do you agree with what we've done? Do you have any suggestions? Do you understand everything? Do you understand the pictures, the information? How can we go forward on this? And then also we use the suitability assessment of material, as well as the patient education material tool for printable materials, and the readability test to guide us through the first few stages of the draft. It then went forward to the language department. And for the language department, they said, okay, how can we make this more easy to understand? How can we make the language more easy to understand? And in the end, they will also assist us in translating this into the different languages suggested by the peer educators. So that is where the health information leaflet is currently. After that, it will go to a practicing healthcare professional, which will then see and use their practical background to say, is this a practical thing? Do you think it will work on an everyday basis and actually working if you implement it? So the results revealed, the first thing that jump out from this is the zeros here, right, for the actionability score. They said, how you provide us with the information, okay, but now what can we do about the situation? Well, what action can we take? What are the steps that we can take to go forward? So we then worked on that, and it improved from there. For the pilot study, we used a questionnaire. This questionnaire contained all the different images within each of the health information leaflets, and they were then asked to assess each image and to say, do they understand it? What do they think when they look at these images? What does these images tell them? Do they understand the information? Is any of this, the picture or the information, culturally offensive to them? And how and all those different things. And then we asked them in the end, they said it's very helpful. And then one of the things that I pointed out is when I asked the question, comments, and any further comments or suggestions, they said yes, because it is not right to smoke in front of child. And that specific statement I will focus on later when I speak about the images. For the readability test, we conducted 9 of them there, and the one that stands out in literature suggests is we use the smoke index. The smoke index will then is more used with health literature, so that is what will be focused on. Now, if you look at this leaflet, this is the image that I was speaking about here. And in this health information leaflet, we generally speak about the health impacts on the human body. And this image was the one that jumped out to them. And you can see from the comments that they made that they could see there is a child, and they could see it's a concern. It was culturally sensitive to them and relevant to them when they used it. So this image alone helped them remember what certain aspects of this leaflet. So when I asked them in the end any further comments or suggestions, this is the image that they referred to. So just the power of the image that is culturally sensitive and appropriate. Other pictures that they couldn't identify, such as these ones here, and then the layout, some medical jargon and things that we use they didn't understand, and so all those different, we improved on that. And then images such as these that were just not, it wasn't adding value in any way. So that was then removed. That was the feedback received there. They still didn't understand things such as brittle bones. They didn't know what that was. They didn't know what a bladder was. But what we included in this leaflet was, they said, we want to see a human body, and we want to see arrows going to the human body and showing us where does all of this happen and what happens. So that was an image that was included there as for us working together with them. And then we said, okay, working on the actionability score, we're going to add some tips on how to then go forward and act on the information provided. And one of the measures there was to provide a game. Because you can have a boarding leaflet with just information in it, but how do you get people to interact with a health information leaflet that is still relevant in a developing country such as South Africa today? So we added the hangman game there, and they did not understand what it was. They had no idea what hangman was. They never saw it. They never played it. So we then had to come up with another way and say, okay, how can we continue with this? So then I compiled this thing, so which is all words, and you have to pair them to words there. And for you to do that, you have to go back and read through the whole information leaflet. So that made them go back to the leaflet, read through it again, identify those words, and see how they link up. and so that can then assist with the retention in the end. And then images, then we tried to make the images, the images were not appropriate for the target audience. We used clip art for an adult audience, which is not appropriate. So we then used more those images that are more realistic. And in the end, we want to we will change the images again because we want to make it more appropriate. The support staff look up to the peer educators. So if we planning on a photo shoot with the peer educators, where we can use them as role models to take pictures of certain things. Obviously, simple images, they won't have images like this, but at least so they can relate to the people in the leaflet that they will be using to make it more appropriate to them in the end. So then in the end, to conclude, we can say that demographics, culture, health, literacy all plays factors in the contributed to tobacco prevalence. Also, it needs to be context specific. The context of South Africa, the context of Rhodes University, the context of, take the context into consideration in a culturally sensitive way, because you can't go to a person where it's accepted in their culture to smoke when they reach a certain age, and I wouldn't say stop doing it, it's harmful to your health, it's hugely offensive. So you need to be sensitive to those cultural practices, and so therefore we go to them and ask them, how can we assist you? How do you want us to assist you with all these things? And then develop their information leaflet through regular interaction with the peer educators, because we are working with them. Whatever we do is because of them and what they asked for us to do. And then capacity building for leadership as well at Rhodes University. And then this nice thing that came out of this extremely interesting book that said advertising, educating, and empowering individuals to adopt healthy lifestyles are the core skills required by a pharmacist in health promotion. And this book is an interesting book because it places health promotion in the context of pharmacy practice. And then also gender empowerment for sustainable development. These are some publications in the field of health promotion, gender leadership, health literacy, and all the mentoring that went on during this process to aid in development. I would like to acknowledge my co-supervisor from Dr. Nicholas Townsend from Oxford University.